senior chemistry major and pre-med student here at Richmond. And I served this summer as the Marsh Fellow at Crossover Ministry Health Center in Richmond. Crossover has 3 locations in Richmond, and one of which is the largest where I worked on the south side. It's on Gordon Avenue. So I wanted to speak a little bit about my work that I did this summer, but before I can speak about the work I did with Crossover, I'd like to speak a little bit about American healthcare and how the work that Crossover does fits into that. So I will try to not overwhelm you with some stats. I know it's late, but I think that it's important to paint a picture of the current situation for U.S. healthcare. So in 2008, the United States total health expenditures grew by 4.4%, leading us to 16.2% of our GDP on healthcare alone. 46.3 million Americans are uninsured. That constitutes 17% of the American population. A recent Harvard Law study said that 700,000 Americans filed for bankruptcy partially due to medical debt. We're the only developed nation in the world that allows this to happen. And so, we, in 2008, 176.3 million Americans received health insurance from their employers. But also, because of the recession and the economic times we're facing, in between 2007 and 2008, 1.1 million Americans fell out of healthcare coverage. And so, with my readings that I did this summer, I worked to better understand American healthcare, health insurance, and I came to the opinion that one of the fundamental problems that we have with our healthcare system, is that we consume health insurance, not healthcare. The health insurance market, the healthcare market itself, is an impenetrable market for the individual American consumer. You can't access the market unless you have health insurance, because prices are negotiated between health providers and health insurance companies at such an elevated level that it doesn't allow for us to enter into that market. So being uninsured, the way that I came to understand it was, it's as if asking someone to lift a car. Health insurance operates as a lever system in the way that I've understood it, that when you use a lever, you can multiply your force, you can use a jack and lift your car, but by yourself it's impossible, and it can't be expected of anyone. And this is the burden that falls upon the uninsured in America right now. And so in Richmond, the national trends play out on a local level. 7.9 million Virginia residents approximately, and 1 million of them are uninsured. 130,000 are uninsured in the greater Richmond area, and 57,000 are uninsured and low income. Uninsured and low income is especially important because it places you in the most at-risk community and demographic for health care issues. And so enters Crossover. So I wanted to give a little bit of background about Crossover. Crossover was founded in 1983, and the founders sought to cross over economic, social, and cultural barriers to provide dental and health care to the ailing Richmond community. For 26 years, it has been driven by volunteer work. I thought this was an impressive stat, that 11,500 clinical hours in 2009 were filed by the volunteers who work there, such as myself. And so I wanted to give you a background about this. These are the services that are provided by Crossover. Primary care, dental, all the way to specialty care. They have a rheumatologist, an on-campus free pharmaceutical system. So they distributed in 2009, I think, upwards of $4.5 million of free medication. It's the largest free healthcare center in the state of Virginia. And so what I did this summer was I worked, these are some pictures that I'll show you. This is a typical exam room. This is one of the dental chairs. There's 3 fully operating dental chairs and full x-ray machine for dental. This is the pharmacy, at least part of it. That's Victoria. She doesn't mind. This is the counseling, mental health counseling area. So I was going to speak about the patient base. Because Crossover is a free healthcare organization, they have to limit who they can offer health insurance or health coverage to. And so the requirements of the patient base are that you must be uninsured and you must earn less than 200% of the federal poverty. So of the people who qualify for this, 75% of the patients at crossover earn less than $20,000 a year, and 34 earn less than $10,000. The last two statistics that I have up here were especially important for my work. 53% of the patients at crossover speak English as a second language, and immigrants are from greater than 100 countries, a lot of which are Spanish-speaking. And so I, as a chemistry major in pre-med, I'm not a Spanish major or minor, but I did have the opportunity to study abroad, both in Peru and in Chile during my time that I've been here. And so I used my Spanish skills to be able to facilitate the provision of healthcare on a bilingual front. So that was my ultimate goal in my Marsh fellowship. So what I would do on a daily basis was I did clinical and clerical translation. Sometimes I would be in the front office answering. There would be a window here which has, sit in the chair. There's a window here which is a patient can come up here and sign in, and they're interacting with me trying to get a new appointment or whatever. And then there's another window to my left where patients after their doctor's appointments would come to me to reschedule or to ask any follow-up questions. And then there's a telephone right in front of me, and it's affectionately called the hot seat because all three are bilingual. And so that was interesting. I was thrown there on my first day, and then Donnie Gonzalez, she was my site supervisor, was wonderful, but she took lunch on the first day as I sat in the hot seat. So that was primarily how I spent my time in the hot seat, of course, but I also was able to learn to prep patients for their visits with the doctor. This could involve taking blood pressure, height, weight, urinalysis, finger sticks for diabetic patients, and most of the things that I was doing were for Spanish-speaking patients. I would take patient histories, and also I was welcomed into the doctor-patient relationship, which was enormously important, and it allowed for a better provision of healthcare on that front, largely for the specialist doctors that came in, because a lot of the primary care physicians at crossover do speak Spanish. So I said that for those that qualify for care at Crossover works tirelessly to meet their needs. One of the largest aims of Crossover is continuity of care, and that really spoke to me during the summer, that there was such a commitment to consistently having the patients have a doctor that they could go to, that they could call their doctor, whereas in free healthcare, most often you go to see a doctor, and you don't have the relationship that you develop there. That's something that the Crossover is committed to, and also because of there's so many different services provided by Crossover, there is a large amount of communication between these different services. So I thought that I could illustrate this best by a story. I've changed the name of the patient, but in 2010, Ann Stewart arrived at Crossover 30 minutes early for her appointment with the mental health counselor, Pam Hill. Following her appointment with Ms. Hill, Ann transferred to her regularly scheduled diabetic follow-up appointment with Dr. Mike Murchie, one of Crossover's internists. Ann, normally a woman of consistently upbeat disposition, entered Dr. Murchie's office, visibly upset, yet holding it together. Reviewing Ann's chart with Dr. Murchie, Mrs. Hill explained the dire circumstance in which Ann found herself, living in abject poverty at the hand of her mentally ill and verbally abusive father, who refused to share his portion of wealth, though he himself was wealthy. Unwilling to betray her father by alerting adult care services, Ann had resigned herself to her situation. Dr. Murchie, after consulting with Mrs. Hill, spent 30 minutes simply listening to and empathizing with Ann. Dr. Murchie, at the completion of the appointment, Dr. Murchie prescribed her medications to be filled immediately in the free in-house pharmacy and asked if she would like him to assist her by calling adult mental health services on her behalf, which he did. Dr. Murchie later remarked, and this quote was important to me, it really spoke to what I believe Crossover is working towards. He said, "Sometimes the immediate needs of a patient overstep the reach of medicine. So you have to do what you can to treat the patient's most pressing needs." Weeks later, Ann returned to Crossover with a smile, having gotten a job and some much needed hope. This is the quality of care patients have come to expect at Crossover Ministry, and Crossover daily meets these expectations. Crossover, however, is not the ultimate solution to Richmond's health insurance issue, healthcare problems. Crossover and other systems like them are not sustainable, and they're not able to be reproduced in the same way they function as safety nets. That's what I entitled this presentation. Was the crossover is the healthcare safety net for Richmond, Virginia. It keeps it afloat, and it's not meant to be the permanent solution to America's healthcare shortcomings. Forced to implement artificial restrictions such as these that I have listed up here. Crossover creates no man's lands, such as those who earn above 200% of the poverty line, yet cannot afford health insurance. So for these people, they're left too rich to qualify for free health care, yet too poor to justify paying for health insurance. And so it spoke to me through all my reading this summer that we have to do a larger revamping of our health insurance system and our healthcare system as a whole. So this is the Patient Protection and Affordable Care Act, which was signed on March 23rd. I'm not going to go through this exactly. I've put some of this stuff up here so you can read it. Most of the things I have listed up here go into effect in 2014. But I would say that this is a good starting point. It's a place to begin a long and tedious process of revamping, redesigning our current system. Our healthcare system deserves the same holistic care that crossover provides its patients, and local bandages cannot save our emerging federal healthcare system. Only with comprehensive systemic changes will Americans receive affordable health care for all. And in the meantime, I think America should follow Crossover's local example of comprehensive care for America's underserved. Thank you to Cassie Price and to the Deborah and Marsh family, and to Dr. Mays and all the people at Crossover. Thank you.